Hi, I'm Kristen at UT Southwestern Medical Center. Welcome to our Migraine Awareness Month chat with Dr. Deborah Friedman. Dr. Friedman is Chief of the Division of Headache Medicine and Founding Director of our Facial Pain Program, which is also part of the Peter O'Donnell Jr. Brain Institute. We definitely want to thank the UT Southwestern Peter O'Donnell Brain Institute, as well as the National Headache Foundation and the American Headache Society for their support of this chat. As usual, if you've tuned in before, be sure to like and share the conversation and also ask questions in the comments feed. Remember that we can't talk about specific medical cases, but we can talk in generalities. And today we want to specifically focus on some of the new migraine treatments that are out there. So Dr. Friedman, welcome. Glad you're here.
It's great to be here.
Absolutely. So, we've been talking, there's been a lot in the news lately about some new migraine treatments, whether they're effective or not. But before we get there, what is the difference between a migraine and a headache?
So a migraine is a very specific type of headache, and there are actually criteria for diagnosing the condition of migraine. So some people with migraine will get a warning. They might see flashing lights or zigzag lines or have other neurologic symptoms before they get their headache, which is called migraine with aura.
Okay.
And then there are people that don't. So that's migraine without aura. So to have a diagnosis of migraine without aura, you have to have at least 5 attacks during your life. And it's kind of like a menu. So you need, of the characteristics of the headache, you need 2 out of the following 4.
Okay.
Which means one of these 4, one-sided, moderate to severe in intensity, so usually it either interferes or interrupts routine activities, pounding or throbbing, and one that I think is actually perhaps the most helpful is worse with routine physical activity. So people with migraine generally want to lie down, they don't want to walk, they don't want to go upstairs. That usually makes their headaches worse. And then of the associated symptoms with migraine, you need 1 out of 2. So the first one is sensitivity to light and noise. And then the second one is nausea and or vomiting. And then if there's anything that doesn't sound quite right on the history or on the exam, we want to make sure there's no other cause. The only difference with migraine with aura is that you need fewer attacks because aura is so specific to migraine. You only need 2 in your lifetime to be able to get a diagnosis. And the aura symptoms generally last less than an hour each.
Okay, good to know. So we have a question here from Kumar. His question is there a genetic factor in this etiology?
So we know that migraine definitely runs in families, right? We hear that from at least 80% of our patients who come to see us in the headache clinic. And there's not one particular gene that has ever been isolated to cause run-of-the-mill migraine, if you will. Not to make light of migraine, but there are some other types of migraine where we have only a few genes isolated. So it seems to be what we call polygenetic, that there are a lot of different genes that contribute to the development of migraine, but certainly it does seem to run in the family, and people who have migraine they're kind of wired, if you will, to get migraine, often from early years, sometimes even shortly after birth.
Okay, interesting. So here's a question from Melissa, and this is getting towards that topic that we're going to get to in a second. She said, I've heard people complain about having headaches when they haven't had any caffeine, and it seems to be a common ingredient in many OTC headache medications. Is caffeine thought to be good for warding off headaches in general?
So caffeine is a dual-edged sword. We use caffeine acutely to treat headaches. As mentioned, it's available in many over-the-counter headache relief products, and it's also available in some of our prescription medications that we use for migraine. The problem is that people who ingest a lot of caffeine every single day, sometimes that can almost act like medication. Caffeine is a medication, and it can cause medication overuse headaches, so it can cause headaches to worsen over time. But even people who are not wired for migraine, they may get caffeine withdrawal headaches. So it's not that uncommon when people miss their caffeine that they'll get a headache. It's not necessarily a migraine. That also happens frequently on fast days. So Yom Kippur and Ramadan and other days that people, for whatever reason, decide to fast, often that produces a headache if they suddenly withdraw from their caffeine.
Gotcha. Really good question, Melissa. Thanks for asking. So related to that, are there ways and steps people can take to prevent migraines. Is there anything that we can do?
Well, that's kind of a long answer.
It is a long answer, yes.
So first of all, some people will be able to identify triggers.
Okay.
And there is some controversy about whether triggers really exist, but people all over the world kind of say the same things. So some people will be able to identify certain foods or alcohol or food additives like monosodium glutamate or artificial sweeteners that trigger their headaches. Stress can trigger headaches, either during the stress or after the stress is over when you're supposed to be relaxed. A lot of people will say that weather triggers their headaches. Heat is worldwide. Heat is blamed on headaches. There's probably something to it. Maybe it has to do with dehydration. I'm not sure.
Okay.
But a lot of people will say that they're like better than the meteorologist at predicting the weather front that's coming in because they get a migraine. Other things. Odors, perfumes, other strong scents are pretty common. For women, any fluctuation in hormones, so menstrual period, ovulation sometimes, any change in hormone level can trigger headaches in women. Beyond that, we recommend that people generally eat a healthy diet, try to avoid their dietary triggers if they can, try to keep a regular sleep schedule. Sometimes this is hard. But going to bed around the same time every night, waking up around the same time every morning. It's kind of like jet lag when you throw your sleep schedule off and it can trigger headaches. Trying to avoid scented products if that's possible, but sometimes, especially in the workplace, it's not possible. And then there are medications that we use for prevention of headaches as well. And even non-medicinal treatments. So biofeedback is often helpful. Cognitive behavioral therapy, stress management. So it's not always necessary to take preventive medications, but there are both over-the-counter as well as prescription medications that we can use to try to lessen the burden.
And that's a great segue to a question we just got from Bridget. So Bridget's question is, what do you know and how do you feel about the CGRP meds? Are you using or prescribing them yet?
Well, Bridget, I can't believe it took you, how long has it been? 10
minutes
to get into that topic because this is hot, right? This is the brand new treatment for migraine. It's been in the works for a long time. And the first of 4 was just launched about 3 weeks ago, which is called Arenumab. The brand name is Aimovig. So just to give you a little bit of background, CGRP stands for calcitonin gene-related peptide. And if those of you who remember back to your high school chemistry, a peptide is a bunch of amino acids that are put together. So this is 37 amino acids, and the peptides are found throughout the body, and CGRP is found throughout the body. We've actually known about CGRP for a very long time, at least 15 or 20 years, because there were studies that were done a long time ago looking at its role in migraine. So the original studies, there were a few of them, one of them actually took patients, not a large number, but 2 handfuls at least of patients who had migraine, and they gave CGRP intravenously to see what would happen. And about 2 hours after the infusion was over, the patients who had migraine developed headaches. Some of them developed a typical migraine headache, and some of them just developed a headache. But people who weren't wired for migraine, they didn't have migraine, didn't really get headaches after they were infused with CGRP. So that was clue number 1. Clue number 2 was measuring CGRP levels in the blood of patients who had migraine before the migraine started, during the migraine, and then after they were treated. So they found that before the migraine started, people who have migraine have just higher circulating levels than the general population. And they actually measured the levels from the jugular vein in the neck because they got the most reliable results that way. Maybe it's because it's close to the head. And then when the migraine started, the CGRP levels went up. And then after they were treated with a triptan, which I believe was sumatriptan back then, their levels came back down. So all of this kind of pointed us in the direction that maybe CGRP is something that's worth looking at. About at least 10 years ago, there was an an oral medication. Well, first there was an IV medication called Elkegepant, or Segepant, which was developed for the acute treatment of migraine. But it was kind of abandoned because it was intravenous.
Right.
And they didn't think people wanted to go do intravenous medication every time they had a migraine. So then another company developed an oral CGRP antagonist, so something that acts against CGRP, that was called Telcagepant.
Okay.
And they tried it for the acute treatment of migraine in clinical trials, and it actually worked great. And then they tried it for the preventive treatment of migraine in clinical trials, and it still worked great, but the problem is there were a handful of people that got pretty severe liver toxicity from it. And it probably wasn't the CGRP itself or the antagonism itself that caused the liver problem. It was something in that tablet that broke down and caused liver problems. So CGRP kind of remained on the table for a while. And then 4 different companies decided that to avoid this whole liver problem, that they would try creating what are called monoclonal antibodies that target either the CGRP itself or the receptors to CGRP. And so the first one that just came out, Aranumab, actually targets the receptor to CGRP, and it binds to the receptor. These are very specific receptors. They don't bind to everything floating around in your body. The only thing this particular receptor binds to is CGRP. And so the drug sits on the receptor and it locks the receptor so that the CGRP can't attach to it. So it effectively decreases the amount of active CGRP floating around in the system.
Okay. Interesting. Well, that was a great question, Bridget, and definitely a hot topic. I've seen a lot about it. We had a bunch of other questions.
I didn't tell you how I felt, though.
You did? Do you want to tell us how you feel?
Well, I can tell you what it did in clinical trials.
Yes, let's say what happened in clinical trials.
This Aranumab was studied in both episodic migraine as well as chronic migraine. The episodic migraine trials included patients who had a minimum of 4 migraine days per month. Okay? And the chronic migraine trials went up to basically not every day. Okay, you couldn't have a headache every day. So there's a pretty wide spectrum of people who were studied in these trials. In the episodic trial, so it's between 4 and 14 migraine days a month, the average increase or the average improvement in the number of headache days was about 3 per month, and the baseline number of headache days was about 8 per month. If you look just at the average of the whole group.
That's a big drop.
Right? So at least a third decrease. About 40% of people who were in the clinical trials had at least a 50% reduction in their headache days. And although it was not one of the, what we call the primary outcome measures, about close to around 20% had a 75% reduction in headache days. And 75% reduction is something we really didn't talk about much. Because if we got to 50, it was a good trial.
Yeah,
right?
75%.
So for the chronic migraine trials, so the average number of headache days in the chronic migraine trials was about 18 per month. And the mean reduction was 6.6 days per month. So better than placebo, because some people did get injections that had no active medication. And again, about the same number. About 40% of people had a 50% response rate, and about 20% of people had a 75% response rate, and there were even a small number of people who had a 100% response rate. Like from the first time they got the injection, which is given once a month, throughout the duration of the trial, they never had another headache.
Wow.
So the primary outcome measure was, recorded several months later.
That's
amazing. It is pretty exciting, and they also appear so far to be quite safe. So there are very few adverse reactions that have been reported, in addition to what people in placebo also got. So the ones that seem to be more common in people who got the active drug were injection site reactions, redness, swelling, itching, and you would expect that because it's an injection that goes right under the skin. And for the higher dose, constipation, but still it was only 3%. So far, this seems to be really well tolerated.
So should patients who experience migraine, should they ask their physician about it if that's an option for them?
I think they definitely should. So currently, and let me just disclose that I am a consultant and I am a speaker for all of the companies that are making the monoclonal antibodies, including Aimovig. So I'm not really here to run an advertisement, but basically the company is offering 2 months of free medication.
Wow.
And they're in the process of negotiating the contracts with various insurance companies. And we're talking commercial insurance companies at the moment, so not Medicare, not Medicaid. And so as long as they are still in negotiation, they will continue to provide the medication at either no cost or minimal cost, $5 a month. We're not sure what's going to happen. We know that there are some insurance companies that have already signed on. Others are still in negotiation. There's actually a big meeting tomorrow out of Los Angeles where the decisions about a lot of this is going to be made. But right now, people can get at least 2 months for free. Now, if they're cut off after that, I'm not sure they're going to be too happy, but depending on their insurance. So I think that in general, we're expecting that the insurers are going to require that people have tried other preventives first, which is similar to what we now go through with Botox.
Right.
But yes, if you've tried other preventives and you either didn't tolerate them or they didn't work for you, or you're on other preventives and you're still not getting optimal relief, I definitely think it's worth talking to your physician about. Now, you also need to know that this is not a simple prescription, right? So there are forms that have to be filled out both from the patient as well as from the provider. And if your provider is not aware of this, they may need to contact the company and find out how to prescribe it.
Okay, good to know. So we've got a question here from Jennifer who asks, what is your recommendation? Now, this is somebody who suffers from migraine. What is your recommendation, given that, for treating menstrual migraines, particularly if you have high blood pressure? Is there anything, what could this person do?
Okay, Jennifer, so I'm assuming you're talking about having pure menstrual migraine. They only come with menstrual periods, maybe a few in between, but really pretty much isolated to the menstrual cycle, and that you are predictable. So one of the options is we could do mini prophylaxis or mini prevention, starting a few days before you know you're going to start getting your migraines. Now, if the blood pressure is not well controlled, not just when you have a migraine, but in general, that somewhat limits the options, right? Because we can't use triptans in people who have uncontrolled hypertension. So if the blood pressure is relatively controlled, then we could think about a long-acting triptan. We could think about a non-steroidal anti-inflammatory, regardless of your blood pressure, assuming you have good kidneys. We could think about almost anything that we would normally use for acute treatment, but just started a few days before you're expecting to get your migraines. If you're already on a preventive, sometimes we'll just actually bump up the dose of the regular preventive medication, again, a few days before you're expecting to get your menstrually related headaches. You may also want to think about devices and ask your doctor about devices that you can use during your menstrual period. So there are currently a few on the market, and they've all been shown to be effective for the acute treatment of migraine, as well as the preventive treatment of migraine.
Right.
So those would be some non-medication options that you could think about during the menstrual period.
Okay, good question. Here's one from Jenny, and you touched on this at the very beginning, so I think it'll be pretty easy. Can diet and nutrition choices affect the frequency and strength of migraines?
So yes, in many people they can. This is not 100% true. But I usually recommend that people keep a diet and symptom journal, and they write down everything they eat and drink, and they write down every time they get a migraine, and we all kind of look back together and see if there's anything that we can pinpoint. And there are lists that you can find on the internet of common dietary triggers. Some people have trouble with dairy. Now, gluten is kind of blamed for everything these days, and there's not a ton of evidence for going gluten-free being helpful. But if you're willing to do that, and it's not an easy thing to do, that might be worth a try. I think dairy is a bigger culprit, though, than gluten.
I've heard that a lot.
The only diet that's really been shown in small studies to be effective is called a ketogenic diet, which is sort of like the Atkins diet on steroids, if you will, without using steroids. So it's a very high protein, low carbohydrate diet. And some people find that that is effective for them. It's not an easy diet to do, and you probably want to do it under medical supervision, but the ketogenic diet might be helpful.
Interesting. Okay, so we have an interesting question here from Ashley Smith. Ashley's question, it's a little bit long, so I'm just going to read through it. I'm interested in the psychosocial approach to chronic migraine treatment. Other than avoiding known triggers, are there any behaviors that are clinically known to improve migraine? Medication, for example? Also, I recently heard of the term pain catastrophizing. Is a person's experience of migraine pain affected by the way we think and talk about our own pain? It's a bunch of stuff there. Maybe we start with the first one. Are there any behaviors that are clinically known to improve migraine? Other than avoiding known triggers?
Well, because stress is often a trigger, stress management, relaxation training, cognitive behavioral therapy, which basically teaches you how to react and cope with stressful things, right? We all have stress in our lives, but it's not so much the stress itself for many people, it's how you react to the stress. So cognitive behavioral therapy can be very helpful. I'm going to give a shout out to one of my colleagues who has a great website about this. Her name is Dawn Buse, B-U-S-E. So it's dawnbuse.com.
Great.
And I suggest you go to her website because this is her area of interest and expertise, and she's written numerous papers about this and done studies. And she's got a lot of things that you can actually do online if you're thinking about, do I need to see a professional or not? I highly recommend her website. Now, catastrophizing, yes, is very common, and you would expect that, right? Because you never know when migraine's going to hit.
Yeah.
Is it going to be, in the middle of my webcast? Is it going to be at my wedding, right? I mean, migraine can hit at the most inopportune times.
Really?
And so it's natural and it's normal to get anxious about when am I going to have my next migraine. And yes, that does affect people's lives over time. And when you look at the psychiatric disorder that is most frequently associated with migraine, it's actually not depression, it's anxiety. And often getting the migraines under control can really improve the anxiety and vice versa.
Gotcha. Great question, Ashley. Here's an interesting one. We haven't gotten one like this before from Scott. Apparently Scott is working on his master's in public health at UT Southwestern UT Health. And he's wondering if there are any centralized resources for population-level data sets for migraine or migraine mitigation planning. Is there anything like that out there where people have done that research?
Yes. In fact, there are large population studies that have been done for migraine. If you want your UT Southwestern, Scott, I recommend you just shoot me an email and I can help you with that. But there are studies primarily done out of Albert Einstein College of Medicine up in New York with Richard Lipton and Dawn Buse and their colleagues. And they've done several very large population studies. But there are also, I believe, insurance databases and other claims databases that can be used. Again, if you want further details, just shoot me an email. It's the formula. You can find me.
Yeah, absolutely.
So can everybody else, probably.
Great question, Scott. Here's one. Now, we've talked a lot about prevention, migraine prevention. Sid Fleeks, his question is, what's the best way to treat a migraine, in your opinion?
Well, it depends on your migraine. It's not an easy question to ask, right? Or to answer. It's an easy question to ask. So it kind of depends on the severity of your migraine and how your migraine comes on. Does it come on gradually? Do you get a little bit of warning that you can treat really early? Or does it come on suddenly and it peaks almost immediately, in which case we have to start thinking about probably injectable and non-oral medications? Do you wake up with migraine? Has it already started by the time you wake up, which again limits the window that we can get some of the medications in that are oral? So, and how severe is your migraine, and are you vomiting? So it really kind of depends on what you're experiencing. So if you have a lot of notice and you don't have a lot of nausea and vomiting, then usually we use oral medications. Some people get good relief with oral over-the-counter medications. Some people will go to migraine-specific medications like triptans or ergots,
Gotcha.
or special formulations of the non-steroidal anti-inflammatory medications, or devices. But if we get to the point where you have severe nausea, and we know that stomach doesn't work well during migraine anyway, so often oral medications don't get absorbed well.
Okay.
But if you have a lot of nausea and vomiting, then we may have to start thinking about getting medicine in, not using your gut. So topical preparations on your skin, suppositories, yes, suppositories. I know Americans don't like them, but they work well.
Yes.
Injections, nasal preparations. So there are a lot of options, and it is important also to treat the nausea,
Gotcha.
right? Not just treat the migraine. People sometimes forget to do that. So very individual.
Good question. Here's one that goes back to CGRP from Carter. Has CGRP, does that have any impact on cluster headaches? I know that cluster headaches are different. I know it's a passion of yours. But how does that work out?
Well, the data are coming out in about 2 weeks. We're having a big migraine meeting, so I can't really disclose anything. But I can tell you that one of the 4 companies that's developing the monoclonal antibody is studying it in cluster, and at least one other one is ramping it up to study it in cluster, and cluster is definitely on our radar screen. We actually participated at UT Southwestern in one of those clinical trials for cluster headache. And so I can tell you that it is in the works, and that there certainly does seem to be a contribution of CGRP in the process of cluster. And so hold tight for another couple of weeks, and it'll be in the press.
Okay, awesome.
I don't want to get in trouble.
Yeah, no, we don't want you to get in trouble either. And we only have a couple minutes left. We've got a couple more questions to go through here, but now's the time to submit those. I know, we've got one. This one is interesting, though. It comes from Jennifer. When medications fail, any different types of medications, what about things like acupuncture, CBD oil where it's legal? You know, do those work? Are they also good options for people to consider? This is from Jennifer.
Acupuncture is worth considering for sure. There are a lot of studies that have been done on acupuncture with migraine. They've had mixed results, but overall they do seem to be favorable, and the risk is very low, and many people find that it's quite helpful. So I would definitely encourage you to do acupuncture. Not a lot I can say about CBD oil. It's never really been studied in migraine. So, and you know, it's the state of Texas, darling, so I can't say much about CBD oil. Yeah,
we are in Texas. Great question, though. All right, 2 more.
And we're law-abiding citizens in Texas. Yeah.
Here's one here from Jenny. And I'm curious if you have a thought on this. How can workplaces help employees with modifications to workstations or schedules to minimize that productivity loss when they have a migraine?
Good question. I'm actually beginning to wonder if being named Jennifer is a risk factor for having migraine. I don't know.
Is that Jennifers?
Okay. So this is a hard battle to fight. You know, I feel your pain. Adjusting the lighting. Okay. Fluorescent lighting is a huge problem.
That's simple.
If they can take out a few of those fluorescent bulbs, that's really helpful. Putting you in an area where you don't have to smell your colleagues' perfume, body odor, what they brought for lunch, okay, that often is very helpful as well. And just kind of eliminating some of the noise level. Using one of those screens over your computer monitor. The flicker's not as big a problem as it used to be, you know, with the older monitors. But sometimes people find that a non-glare screen is very helpful for them. And just basically trying to give you some space where you're not exposed to a lot of the things that bother people with migraine.
Okay. Good question, Jenny.
You know, it really should be covered because migraine is considered a, you know, disability by the American Disabilities Act. And so employers legally should have to respond to this, but you know, based on the experience with my patients, I can tell you it is an uphill battle in many places.
It can be, and that gets to Jennifer's question. Apparently, a different Jennifer. She says, my neurologist is...
It's the same person.
I think, well, they all have different last names. But Jennifer says, my neurologist is a goddess, but we've hit a wall with treatment. When and if insurance stopped paying for preventive medications, what other options should she or somebody like her look at?
I'm not sure why your insurance would not pay for preventive medications.
Correct.
And it's hard to answer that question without knowing exactly what you've tried and all that kind of stuff. But, definitely investigate the CGRP monoclonal antibody, Aimovig or Brenumab. It's not an insurance issue at all right now, so I think that is worth trying.
Okay.
And, I tell my patients, they come in and they say, I've tried everything. It's very rare that we see people that have actually tried everything.
Okay.
So there's usually something that somebody can come up with that's different.
Okay.
And even considering devices again, that a lot of times I think it's just not on our radar screen to think about devices.
Okay. And we did not get to devices today.
Well, we'll have to do it again.
We will. So with that in mind, we've got to wrap up now. Is there anything, Dr. Friedman, that you want to make sure that people watching understand about these new preventive strategies?
So like I said, the first one just came out. There are 3 more in the offering, and they work differently. So the other 3 attack the CGRP, so that they bind to the CGRP, so it can't work. This is the one that's out now is different. So the next 2 out will probably be in a subcutaneous injection under the skin. The 4th one out, in all likelihood, the 4th will be an intravenous infusion given every 3 months.
Gotcha.
There are also orals that are in development. There are at least 3 oral medications that target CGRP that have reformulated it, so they're getting rid of the liver toxicity issue, that are currently in clinical trials, and they should be out within the next couple of years as well. So there are just a lot of exciting things going on in the world of migraine and headache. It's fun to be a headache specialist now because we have so much to offer, and again, I'm very optimistic that we're going to be able to help a lot of people.
Perfect. Awesome. Well, I want to say thank you to everybody for tuning in and for all the great questions. As usual, this will be available here on this Facebook page. I encourage you to share it, come back, rewatch it if you need to, share it with friends and family. It'll also be available on our YouTube channel later this afternoon, so if you know people that aren't on Facebook that would benefit from this information, please share it there. And I just want to thank Dr. Friedman for your time. It's been a great conversation.
Thanks, it's my pleasure.
Absolutely. We will see you next time.